So we'll go to the second lecture in the third section. So patients with bronchiectasis are vulnerable to not only to a mycobacterium or NTM, but still fungal diseases also are common diseases. So we previously thought it's a rare occurrences, but now with the advance in diagnostic facilities, increase the detection rates. So these fungal diseases may be recurrent in some patients, may be recurring. So we have got a consultant who is going to talk about about bronchiectasis and fungal lung disease. She's Amelia Berkerson. She's a consultant respiratory physician, Host Defense Department, Royal Brompton Hospital, Guy St. Thomas's NHS Foundation Trust, United Kingdom. So her special interest in bronchiectasis, fungal lung disease, and chronic respiratory infection. She will be joining live for a question and answer session once at the end of this lecture.
Hello, my name is Amelia Berkerson and I'm a consultant respiratory physician at the Royal Brompton Hospital in London. As part of my work, I help to run a specialist fungal lung disease clinic, and I would like to thank the organisers for asking me to give this talk today. So, what are fungi? Fungi are a diverse group of eukaryotic organisms, including yeasts and molds. They absorb nutrients from their environments. Now, while fungi play an important role in the kind of general ecosystem, they also have a critical role in human disease as pathogens that can cause infections, they can trigger allergic reactions, or produce harmful toxins. There are two main groups that are relevant to human disease: multicellular filamentous molds such as Aspergillus, Scedosporium, or mucormycosis, or single-celled yeasts such as Candida and Cryptococcus. In terms of respiratory disease, by far the most significant fungus is Aspergillus fumigatus, which is responsible for about 80% of cases of allergy and infection. So Aspergillus is a ubiquitous fungus. It's in the environment. It lives in soil, compost, plant material, and it can be found growing in poor domestic conditions. So, for example, where damp is a problem. So we all inhale thousands of conidia every day, and in an immunocompetent host, inhaled conidia are trapped in the mucous layer, and then they're removed from the lungs by mucociliary clearance. If a spore happens to evade mucociliary clearance, then it will be phagocytosed by airway macrophages without inducing an inflammatory reaction. Now, problems arise if defects in the innate immune response allow conidia to persist in the airway. If that occurs, then conidia can start to swell and germinate. The relatively immunologically inert outer rodlet surface layer will crack open and expose the underlying polysaccharides that make up the conidial cell wall, such as beta-glucan and galactomannan, and these polysaccharides are very strong and immunogenic and will be recognized by pathogen recognition receptors on the cell membranes of immune and epithelial cells. So fungal exposure to epithelial cells and immune cells will induce production of cytokines such as IL-25, IL-33, and TSLP, which activate group 2 innate lymphoid cells and initiate Th2 type differentiation of naive CD4 cells. So activated ILC2 and Th2 cells will then in turn produce IL-5 and IL-13, which mediate eosinophilic inflammation, hyperplasia of goblet cells, and airway remodeling. And it's these pathways that are activated and exaggerated in ABPA. Fungal antigen exposure can also recruit dendritic cells and will drive the production of other cytokines such as IL-6, IL-12, and IL-23. This in turn will trigger proliferation and differentiation of Th1 and Th17 cells. So Th1 cells are important because they activate macrophages through the secretion of interferon gamma, whereas Th17 cells produce IL-17 and IL-22, which mediate neutrophil recruitment and the production of antimicrobial peptides by epithelial cells. Now, while these responses are important for clearing fungus from the airways, when you have chronic fungal colonization and chronic antigenic stimulus, you get unrestrained Th17 activation, which can drive progressive tissue destruction, remodeling of airways, and tissue necrosis. The interferon gamma response and neutrophil recruitment are really important for clearing fungus. And it's interesting to know that in CPA patients, we found defects in interferon gamma production And we know that neutropenia is a key risk factor for invasive fungal disease. Now, if the key components of this immune response fail, particularly due to a lack of neutrophils or due to a lack of functional CD4 cells like you get in HIV, then it is much harder to contain germinating spores. So hyphal growth will continue and penetrate the epithelial layer, reaching down to the basement membrane, and in neutropenic cases can cause angioinvasion. Bigger pardon. Now, I'm not going to cover invasive aspergillosis in this talk, but it is important to understand the pathophysiology of Aspergillus infection and how the nature of the host response, or lack of, will determine the nature of the clinical presentation. So, Aspergillus lung disease is a term that covers quite a broad spectrum of pathophysiological presentations. The key factor that determines the type of fungal lung disease that you might get is the nature of the host immune response to that fungus. So, as you can see represented on this slide here, fungal lung disease can range from invasive infection in patients with very severe immune defects through to chronic cavitary and fibrosing aspergillosis and aspergillomas in patients with underlying chronic lung disease, and probably some as yet undetermined milder immune defects, all the way through to ABPA and severe asthma with sensitization in those who have an exaggerated hypersensitivity response to fungal exposure. So I'm going to start the clinical part of my talk by talking about allergic fungal airways disease. So AFAD is a term which covers a range of clinical phenotypes, so including severe asthma with fungal sensitization through to various forms of ABPA. In terms of pathogenesis, what they all feature is an immunological response which is characterized by eosinophilic inflammation and B-cell switching to IgE production in response to a repeated fungal antigenic stimulus. So ABPA can be subclassified. So we talk about serological ABPA, so that's when you have the serological changes of ABPA, the IgE response, but without radiological changes. You can also get ABPA with a variety of radiological manifestations. So you get ABPA with bronchiectasis, with mucus plugging, with high attenuation mucus, and with chronic fibrosis. Allergic fungal rhinosinusitis occurs when these IgE pathways are activated in the upper airway. So over the years, there have been a series of proposed diagnostic criteria for ABPA, from the very early Rosenberg and Patterson criteria to the most recent 2024 modified Isham criteria. Now, all of these are based on a combination of clinical, serological, and radiological features. The mandatory components for a diagnosis of ABPA are the presence of a positive Aspergillus IgE and a significantly raised total serum IgE. In the earlier criteria, such as the Rosenberg-Patterson criteria, the diagnostic cutoff for total IgE was set at 1,000, but in the more recent modified Isham criteria, this has been reduced to 500, which increases the sensitivity of this test from 91 to 98%. As well as meeting these two essential criteria, diagnosis of ABPA requires an additional 2 out of a raised Aspergillus IgG, a raised eosinophil count over 500, and consistent radiographic changes. Another interesting change that was put in the latest criteria is the recognition that there are predisposing conditions beyond asthma and CF, and that ABPA can occur in the absence of any known underlying condition as long as there is a compatible clinical radiological presentation. So here I've got some x-rays which are really showing the various x-ray presentations of ABPA. So in image A, you can see that there are areas of consolidation in the right lung and trantract capacities in the left lung, which represent bronchioles. In images B through to D, you can see a series of chest radiographs which have been performed over time in a patient with ABPA, showing fleeting pulmonary capacities in B and C, and then a clear X-ray in D after completing treatment. In X-ray E, instead, you can see areas of subsegmental collapse, which is another presentation of ABPA. So it's important to remember that in about 50% of patients with ABPA, their chest X-ray will be normal. So in these cases, it's the CT really which plays a critical role in diagnosis. And here I've shown you a number of CT slices from patients with ABPA. So in images A and B, you can see the quite typical central bronchiectasis. However, it's important to remember that bronchiectatic airways can extend to the periphery as well in ABPA, so you can see that in slides in image C. Mucus plugging of dilated bronchi, otherwise known as bronchoceles, and central lobular nodules in a tree and bud pattern are shown in images D and E and are also common manifestations. In image F, you can see what is considered the pathognomonic CT change of ABPA, which is high attenuation mucus. And then finally, in image G, you can see central bronchiectasis with vast areas of mosaic attenuation, which shows you that the small airways component of ABPA. So if we move on to management, the key tenets of ABPA management are to target the two interdependent pathological processes which occur. That is, persistent fungal airways colonization and a dysregulated type 2 inflammatory response to that fungus. The goals of treatment are to achieve symptom control, to achieve remission of an ABPA flare, to prevent further exacerbations, and to halt the progression of bronchiectasis, all the while trying to minimize treatment-related side effects. Now, historically, the treatment of ABPA has really been dominated by steroids, and in particular by very prolonged courses of high-dose steroids. Now, over time, we've come to recognize the very deleterious side effects of this prolonged steroid exposure, so treatment strategies have evolved. And really leading the way by far in generating the trial evidence for progress in the field of ABPA has been the work of Ritesh Agarwal's group based in Chandigarh. In 2016, they published the results of a landmark trial where they randomized patients to receive either a high-dose course of steroids, starting at 0.75 milligrams per kilogram, and gradually weaning over 6 to 12 months, or a medium-dose trial group who had started at 0.5 milligrams per kilogram and weaned over 4 months. And in this trial, they found that although at the early time points at 6 weeks, there was a greater serological and composite response, the change in FEV1 was similar in the two groups, as was the time to first exacerbation after stopping treatment. So really, this trial has shown us that you don't need to give really, really massively high doses of steroids for months and months and months on end. And that kind of treatment really is becoming a thing of the past in the world of ABPA. So while steroids are treating one of the pathological processes, i.e. the dysregulated host response, antifungals aim to reduce the antigenic burden. So in 2016, Agarwal's group again published another landmark trial, which was a head-to-head study of itraconazole versus prednisolone, which showed a similar decline in IgE and improvement in lung function at 6 weeks, and similar exacerbation rates at 1 and 2 years. Again, side effects were more common in the steroid group. So what this trial shows us is that both steroids and itraconazole are options as first-line treatments for acute ABPA. Now, demonstrating a benefit from combined therapy has been less obvious, and in the 2022 trial of prednisolone versus combination therapy, there was not really a clear difference in the study group overall in terms of outcomes. However, on a post-hoc analysis of the data, you can see that there was a small signal for certain groups of patients who benefited slightly more from combination therapy, and those were really the patients who had eosinophil counts over 1,000, who had more than 10 bronchiectatic segments involved, or who had markers of increased fungal burden, so patients who were growing aspergillus in the sputum or who had significantly raised aspergillus IgG, where it makes sense that an antifungal might provide additional benefit. Now, one of the more exciting developments in the past few years in the world of ABPA has been the potential for using asthma biologics. Now, none of the asthma biologics are licensed as yet for use in ABPA, but they are being used off-license in patients who are either inadequately controlled on antifungals or intolerant of antifungals, or who remain steroid dependent. Just as biologics have reduced steroid exposure over the years in asthma, we can only hope they will have a similar effect in ABPA. The evidence we have so far to support biologic use in ABPA is relatively weak, unfortunately. It's mainly case series and a couple of small RCT trials for omalizumab and dupilumab. The most recent trial was of dupilumab, and that was in fact the largest trial so far of 62 patients with asthma and ABPA. In our clinic, we are increasingly using biologics, and there's certainly a need for more and larger biologic trials in this population. There is some evidence for nebulized amphotericin. It's not terribly strong. There was one meta-analysis of a few case series where they used nebulized amphotericin, saw a signal of reducing exacerbation rates. So this is an option for patients if they are intolerant of azoles and they're still exacerbating. Other inhaled azoles, for example, inhaled itraconazole and a novel azole called opolconazole, they are still undergoing phase 1 and phase 2 trials. Ritesh Agrawal's group again, this year they've published some data from a phase 2 study of inhaled itraconazole in ABPA patients, which is quite promising. And certainly inhaled azoles would help us avoid some of the toxicities associated with oral azole therapy. So I'm going to move on to chronic pulmonary aspergillosis next. So CPA is really another umbrella term which we use to describe several conditions which are united essentially by the presence of a chronic fungal infection rather than an allergic response to fungal antigens, which is what happens in ABPA. The most common form of CPA is chronic cavitary disease, which, if left untreated, can progress to chronic fibrosing pulmonary aspergillosis. Less common manifestations of CPA include aspergillus nodules and single aspergillomas. All of these entities are found in non-immunocompromised patients who do, however, have underlying lung disease. Subacute invasive pulmonary aspergillosis, what we used to call chronic necrotizing pulmonary aspergillosis, is a slightly different beast. It tends to be more rapidly progressive than other forms of CPA, and it's found in moderately immunocompromised patients, so patients on long-term steroids or on ITU. So aspergillomas. So aspergilloma essentially is when you have a pulmonary cavity or a very ectatic airway which contains a fungal ball. You may well have serological or microbiological evidence of aspergillus infection, but not always. And aspergillomas can be thought of as simple or complicated. We call them simple, really, when they have no minor or no symptoms and there's no radiological progression over time. And we call them complicated if patients are symptomatic, and usually that manifests with hemoptysis or if their cavity is growing. So how do we manage aspergilloma? If they're simple aspergillomas, if the patient's completely asymptomatic and there's no progression, and importantly, if they're not immunocompromised, then you can watch and wait with them without necessarily treating them. But you do need to watch them quite carefully. If the patient's symptomatic, however, or if they're immunocompromised, or if the cavity is getting bigger, then surgical resection is really the best option if the patient is fit enough, because essentially it's a curative option. Pre and post-op antifungal treatment is important to think about. There's not really any very firm evidence that you need to use it, but we tend to have a very low threshold for giving antifungal therapy perioperatively, because the consequences of having not given antifungal perioperative treatment and then there being spillage during surgery are serious. So the prophylaxis we use is either azole or echinocandin for around 6 to 12 weeks. If there is a spillage during surgery, if the cavity ruptures containing the fungal ball, then it's important to tell your surgeons to wash out the pleural space with either an amphotericin solution or taurolidine, because otherwise you can end up in a situation where you have essentially like a fungal infection in the pleural cavity, which can be very, very difficult to treat. For those patients who aren't fit for surgery, then bronchial artery embolization can be helpful for managing hemoptysis, but otherwise it's antifungals. So chronic fibrocavitary aspergillosis. So here, that's where you have one or more thick-walled cavities that contains intraluminal material. There's generally evidence of progression over time, so either new cavities forming or enlarging cavities, or increasing pericavitary infiltrations, or increased pleural thickening, or in fact, increasing fibrosis and volume loss. You've also got to have serological or microbiological evidence of Aspergillus infection, so they're either growing it in sputum or they've got a positive Aspergillus IgG. And this kind of condition tends to happen in people with underlying damaged lungs, so either post-TB or bronchiectasis or emphysematous lungs or fibrotic lung disease or lung cancer, something like that. And they present with what symptoms you'd expect from a chronic infection, a chronic pulmonary infection, a consumptive process. So they have cough, sputum, hemoptysis, weight loss, fevers. And this is what it looks like radiologically. So they've got thick-walled cavities, may well contain an aspergilloma. They've got surrounding fibrosis. The pleura is thickened around that area, and they've got volume loss. There are a number of guidelines that have been published over the years on management of CPA. So the original ones back in 2016 from David Denning, published in the ERJ, and the IDSA guidelines. And then more recently, the BTS has published a clinical statement on fungal lung disease. And these are all very useful resources. So the mainstay of treating CPA is antifungals, and triazoles are the standard of care. Now, the trickier question in these situations is how long do you treat patients for? So again, Agarwal's group published a study where they compared 6 months to 12 months, and there's really quite a clear signal that patients who had 12 months of therapy had much lower rates of relapse post-treatment. So 12 months is the standard that we give treatment for. There's not really any good evidence that any one azole is better than any other. So that our choice tends to be guided by the fungal sensitivities, by the side effect profiles, and by drug availability. In our clinic, we use itraconazole as our first-line option. So, unfortunately, there are high rates of recurrence and relapse after coming off treatment after those 12 months. There are certain risk factors that can help guide you. So, for example, if they've got bilateral disease or extensive multilobar disease, or if they're immunocompromised, they're at a higher risk of relapsing. And some of these patients do need to be on lifelong treatment. There will be a subgroup of patients who can't tolerate azoles, or who progress despite being on azole therapy, or who have pan-azole resistant aspergillus. And in those cases, you can try IV antifungals, either echinocandins or amphotericin. Prolonged amphotericin use is limited by toxicity, predominantly renal toxicity, so we often use cyclical IV echinocandins. So when you've put someone on treatment, then you want to know if they're responding. So the main way of determining that is by repeating the radiology. So we repeat a CT at 3 to 6 months after starting treatment to see if there's been any improvement. Also, if you take someone off treatment, if they've done their 12 months and they're feeling better and their CT looks a bit better, you pause treatment. You need to repeat their scan after an interval to make sure that there hasn't been a relapse. You can also monitor Aspergillus IgG, but we don't have enough data to really support using this as a sole marker of clinical response.
So, thank you, Dr. Amelia, for a very insightful and informative lecture on fungal lung diseases and bronchiectasis. So, now the floor is open for questions.
Dr. Amelia, thank you very much for joining in live. And I think it is afternoon there, and it's a pleasure. I'm Naranjan, one of the pulmonologists, and just to let us know, when we have treatment of ABPA and invasive aspergillosis, do you find any significant difference between itraconazole and voriconazole when you're treating them?
No, not in terms of efficacy, not really. And the most recent trial didn't really pick up a significant superiority signal for voriconazole. I think the main difference I find is about tolerability. Personally, in my experience, I find that people tend to tolerate itraconazole a bit better than voriconazole. and because boric absorption from the pharmacokinetic potential of voriconazole non-linear, it can be a little bit difficult to get stable therapeutic levels. Not impossible, but can be tricky at times. So we tend to use itraconazole as our first line, but mainly the choice of our antifungals is guided by drug tolerability, resistance profiles in the aspergillus, and basically what's available to us.
I think I agree with you because in Sri Lanka also we have itraconazole and it's rather cheaper than voriconazole because we have to consider the price aspect as well. And voriconazole is a red light antifungal, so we have some institutional problems when we are using it as well. So if the efficacy is okay, I think that'll be a good point in our patients management. And the second thing is when we talk about chronic aspergillosis, no, I know it might be a difficult question, the duration of treatment, because patients vary in their response, and what are the solid features that you will go for to see a good response in a patient, and when you will decide that okay, I'm stopping treatment in this patient.
Sure. Yeah. So generally, I would say in across the group in CK, I'd say that 12 months is a minimum, and that is a very clear signal from Mitesh's study that 12 months is better than 6 months. Beyond 12 months, I think if they have localized disease and they've responded well, so in terms of what am I looking for in terms of a response? So radiologically, you're looking for potentially reduction in the pericavitary consolidative changes, sometimes even a shrinking in the cavity, certainly in absence of any new cavity formation or expansion in the cavity. Looking at the size of the mitochondria in the cavity is not really terribly reliable, so I look at that. I look at more of a feature of the cavity. If the cavity wall is thinner, that can be another sign, or if there's less pleural thickening, less pleural reaction, they can also be useful indicators of a response. We have, in a few cases, started using PET a bit. So if you get a PET scan, using a PET scan pre-treatment and then post-treatment can sometimes be helpful. We don't really have any larger data sets on how the reliability of PET in CPA, but theoretically, so it makes sense it could be a helpful tool. So we've started to use that a little bit. Particularly, we had a cohort of patients at Brompton who had essentially like burnt out sarcoid, who then developed secondary CPA. So PET can be quite useful in that context. The Aperture's IgG, we do tend to monitor it in treatment, but unfortunately it's not quite reliable enough, or we don't have data really to say that one can safely use that as a measure, certainly not in isolation, but I think it's a part of the composite response that you'd be looking at. Also want to look at symptoms, so are they clinically, has their weight stabilized, have they stopped coughing up blood, are they generally feeling better in themselves? So look at all those markers for response. So if someone has responded clinically, their CT is improved, then and they've got localized disease, and I might stop at 12 months. If they've got really very expensive disease, or there's only been a partial response, or they've got a significant risk factor for relapse, so for example, if they're immunocompromised, then I would probably continue for longer. I don't think there's really a perfect answer in some cases as to how long you go on. So, I think it does sometimes become a very kind of individual case, basically risk assessment about starting and about continuing or stopping treatment.
Right. Thank you, Amelia. I think you did a very nice lecture about the fungal lung disease. I am Niranjan. I am one of the consultant chest physician from District Chest Hospital. I have two questions about chronic pulmonary aspergillosis. The first one is sometimes when we use itraconazole in the patient, sometimes they are not tolerating sometimes very high doses. So what is your experience using low doses and the high doses in itraconazole regarding the a treatment outcome of the patient? That's my first question. And the second one, when you are treating like 12 months with antifungal treatment, other than the clinical aspect, what are the things we can use as a monitoring? I want to specifically highlight about Aspergillus specific IgG, in which intervals you are thinking better to do Aspergillus specific IgG in monitoring aspects.
Sure. Okay. So in terms of the itraconazole, there are tolerability issues with itraconazole as well. Mainly, I find kind of GI side effects or ankle swelling. People who potentially have slightly impaired cardiac function at baseline, itraconazole can sometimes not be the best option. In terms of low versus high dose, it really depends on how well they're absorbing it, if you can achieve a therapeutic level. So TDM monitoring is really important with antifungals because the absorption of itraconazole can be variable and be affected by things like if they're on a PPI, then the absorption will be affected. So if they're getting side effects of a higher dose, if they can achieve a therapeutic level with a lower dose, then that's fine. If they can't achieve a therapeutic with a lower dose, and they're not tolerating the higher dose of itraconazole or a dose that is sufficient high to give them a therapeutic level, then I think you're going to try and change your antifungal, because there's no point giving someone an antifungal for 12 months if you've never actually achieved therapeutic levels. That just gives you a side effect without any significant benefit. So then I would switch to something like, usually I would switch to itraconazole. But in my experience, people tend to tolerate that a bit better. In terms of monitoring, so the Aspergillus IgG, so as I said before, we do monitor it. So usually I would monitor it about 3 to 6 months after starting treatment, and then do that again 6 months later and see if there's a response. One would hope, that it would come down, but it doesn't in 100% of cases, depending on basically the fungal burden. So if they've got massive mycotomas, and in some cases it's not necessarily going to come down that cleanly. So although it's part of the picture, I wouldn't, if their IgG has come down, say 50%, but their scan still looks really bad, I wouldn't feel confident that the patient necessarily had an adequate response. So, Aspergillus IgG, unfortunately, we haven't got the same data that it correlates to response as closely as, for example, serum total IgE does with ABPA.
Right, thank you.
Thank you, Dr. Amelia. We sincerely appreciate your time and expertise you shared with us today. Thank you again. Thank you.